Good evening, everyone. Thank you all for being here. My name is Katie Van Haste. I'm Senator Sanders' State Director. We really appreciate all of you coming out tonight to have a great conversation. Just one housekeeping note, we're going to hear from Senator Sanders, Dr. Leffler. They're going to have a conversation. We're then going to open it up to your questions. I'd ask that folks stay seated until these two are done talking. Then we'll let you know it's time for questions. We're going to have 2 microphones on either side aisle. If anyone has any mobility issues, just raise your hand and a member of our team will bring a microphone over to you. And with that, I will introduce your Senator, Bernie Sanders.
Thank you. So let me thank everybody for coming out on this beautiful, warm evening. I don't have to tell anybody here that the country today faces enormous problems, that the administration in Washington is making a bad situation worse. So before I go any further, I hope you do know, is that it is my view, and I think the views of the vast majority of the people of the state of Vermont, that health care is a human right, not a privilege. And that the United States must join every other major country on earth in guaranteeing health care to all people. The health care system that we have in this country, and I tell you, I've been all over the United States, and every meeting I go to, I ask the same question: do you think the health care system in America is broken, it's dysfunctional? Overwhelmingly, whether you're Democrat, Republican, Independent, people understand this system is deeply broken. We spend, roughly speaking, twice as much per person on health care as the people of any other major country on earth. We are now spending, adding all health care costs together, $15,000 for every man, woman, and child. Family of 4, $60,000. Now, you would think if you spend that huge amount of money, you would have the best healthcare system in the world. We don't. We have one of the worst healthcare systems in the world. 85 million Americans are uninsured or underinsured. 50, 60,000 people a year die because they don't get to a doctor when they should. We don't have enough doctors. We don't have enough nurses. We don't have enough mental health specialists. We don't have enough dentists. All over the country, people wait months before they can get into a doctor's office, even when they have good insurance. So what I want you to know, which is not the discussion for today. Today I want to focus on what we could do in Vermont at this moment. But overall, we're going to continue the fight, and we are gaining more and more support. Half the Democrats in the House support Medicare for all. About 40% of the Senate supports my legislation, Medicare for all, and as I go around the country, the support is there, the polling is there. But we got some very powerful special interests in the insurance company, drug companies, big hospitals that we've got to take on. But the momentum is with us. But tonight, what I wanted to do is not talk about the broad issues because we're not there politically yet. I wanted to talk about where we are right now in the state of Vermont. And as you all know, it ain't a pretty sight. In a country which spends more than any other country, we are at the top of the list, or close to the top of the list, in what we spend here in the state of Vermont. We spend a hell of a lot of money. People can't afford it. People are going without. People are paying health care costs, and they can't pay their rent, and so forth and so on. So tonight, I'm very pleased that we have Dr. Steve Leffler with us. Steve is the CEO of UVM Health, runs the hospital, runs the entire network. And what I am going to suggest to Steve tonight is because in this country and in this state, we do not have a system. There is no healthcare system. So Steve, as the leader of by far the largest entity in the state, Steve plays with a $4 billion budget, which is a lot of money in the state of Vermont, that he is going to have to be much more aggressive, break through the status quo. Status quo is not working, and kind of be not only a good bureaucrat, but a visionary to see how we can lower the cost of healthcare in this state, improve access, and do all the things that we want to do. All right, so that's the goal tonight, is we're going to stay focused on Vermont issues, where we are. I'm going to challenge Steve on a number of the concerns that I've heard from people all over the state, and then we'll open it up to your questions. So let me begin by thanking Steve very much. When I suggested this a while ago, Steve jumped at the opportunity. I'm glad that he's here. I'm glad that he's in the position that he is. Steve was born and raised in Leicester, Vermont. So he is a local boy who knows the state and who loves the state. He went to UVM, went to UVM Medical School, worked in the emergency room as a physician, is now, among other things, a professor at medical school, and so forth and so on. So Steve, let me start it off by asking you the question that is on people's minds. What are you going to do to lower the outrageously high cost of health care in the state of Vermont, right?
Thank you. Easy one first, thanks. I appreciate that. So it is true that healthcare costs in Vermont are... Is this green? Better? Okay. All right, thank you. So it is true that healthcare costs in Vermont are quite high, and we could spend a lot of time talking about why, but that doesn't really help. But we do have to understand the situation. I will tell you, while it's expensive here, it's also expensive across the country. And I have been in healthcare for my entire adult life. I came back to Vermont in 1993 after finishing my residency in emergency medicine, and I've been at UVM since '93 in a wide variety of roles, but practiced emergency medicine for close to 30 years. And so the first thing I'll say is, I actually believe the United States has a really good sick care system, but not a good healthcare system. We're quite good if you're sick, and we can do amazing things in this country. And if I was very sick, there's no place else in the world I'd rather be than the United States and one of our big academic hospitals. We do amazing, miracle things every day to people who need them. The problem is, we're terrible at keeping you healthy and not needing that. Lots of other countries have figured that out and do that really well. So if you're a sick care system, which is really what I think we have in America, then you build a system to take care of sick people, and we've done that pretty well, and now we're kind of at the breaking point. Vermont, I think, is feeling it first. Vermont's pretty small. We don't have a lot of people. We're rural. We're a little older than average, which means older people need a little more health care. We know that. And we have a relatively small number of people who have commercial insurance. For my whole career, we basically have taken the cost that we can't cover by Medicaid and Medicare, and I don't want to spend too much time about this, and pushed it to commercial insured people. So the commercial insured premiums are always higher to cover those costs. There's not enough Vermonters with commercial insurance to be able to cover that anymore, which is a big problem. And one of the answers is to get more young people who want to move to Vermont and live here and have this amazing life. But right now, that's not going to fix it this year for your premiums. And so what can we do better? But I am encouraged because I just saw Vermont do something really amazing just in the last 5 years. I firmly believe that Vermont had the best response to COVID in the United States by a lot. And we did that by all working together. We did that by taking care of each other, looking out for each other, wearing masks when we should, getting vaccinated. All the hospitals worked together. We worked with the FQHCs, worked with the private physicians. We figured out how to take great care of each other, better than anyone else in the country, maybe in the world on some things. And that was really hard. So if we can do that, we can figure this out. I do believe it. So now I'll get to you how. We have to figure out how to get more people care with really what we have. Use lower sites' cost of care better than we do now. Try and figure out how to partner better with all of the healthcare parts of the system that we have right now. So how do we use our FQHCs better, our private primary care practices? How do we use our smaller hospitals and make sure they are having enough patients there, because it's true, their daily costs are a little lower than an academic medical center. An academic medical center has high daily costs because every day we have a 24/7 emergency department that's ready to take care of you if you have trauma, a newborn baby, cancer, you need heart surgery. Those are high fixed expenses. So we have to figure out how to get people to all the different sites in Vermont better. And there's a lot I hope we talk about in this time here tonight about how we can do that better. So I do think there's lots we can do.
Okay. Thanks a lot, Steve. All right, let me start off with some of the questions that people have asked me. Blue Cross Blue Shield has noted, as have others like the Green Mountain Care Board, that UVM Medical Center is the most expensive place to get certain procedures in the state of Vermont. For example, my understanding is that the cost of an MRI at UVM Medical Center is over $6,500, while at Dartmouth Hitchcock it's about $5,000, and at Northwestern Hospital in St. Albans it's around $2,800, much cheaper. Why are your services so much more expensive than other Vermont hospitals, and what are you going to do about it?
Thank you. I'll start with what we're going to do about it. We just finished our contract with Blue Cross Blue Shield for 2026, and our outpatient procedures like an MRI on average are down about 16%, and specifically for many of our imaging procedures down 25%. So our costs are coming down. They should be much closer to in line with Dartmouth. Why is that still more than it is at Northwest Medical Center? It has to do with, once again, our fixed costs and where there's not a lot of things that we do in healthcare right now that cover their own expenses. And so we're constantly playing a game. We're moving dollars around to make sure we can cover costs that don't. So there's many things that we do, oftentimes mental health care, many pediatric services, many services in the emergency department lose money. And so you're constantly moving the game around to try and have coverage. And we take care of sicker people with our MRI machine. It's oftentimes a different machine that can do everything from taking pictures of your heart to more simple things, meaning we have a different level of machine. So it's complicated, but the end I want you to hear is our costs are coming down for outpatient imaging and should be much more comparable to Dartmouth and other academic medical centers.
Good. Now, related to that, as you know, some surgeries and procedures, like colonoscopies, can be performed outside of a hospital in what is called an ambulatory surgical center. It is my understanding that New Hampshire, which is a state about twice our population, has over 30 of these ambulatory surgical centers providing relatively inexpensive care, while here in the state of Vermont we have just 2. What are you going to do to move care out of the expensive hospital framework and into these less expensive surgical centers? Can we learn something from New Hampshire with regard to that?
Yeah, it's a great question. And I don't know this for a fact, but if I had to guess, I would bet that almost all of those 30 New Hampshire surgery centers are in the southern part of the state. I'd kind of call them northern Massachusetts, where there's a lot of population. And there's big companies that have a lot of people that have private health insurance. Surgery centers do great care for the right patient population. They do a really good job if you are healthy and need a quick colonoscopy. They deliver super high quality care. They don't take care of oftentimes people who are more complicated or have issues. They don't take care of oftentimes people who are uninsured or maybe oftentimes have Medicaid. They're very good at a niche of a population they care for, and they can do it cheaper, for sure. We work very well with the Green Mountain Surgery Center. I've been out there before. I've met with their leadership. They're a great addition if you can get care there. But also, they don't have some of the overhead that we have in hospitals. They don't have a 24/7 emergency department. If you have a complication after they close or on the weekend, you're coming to us. If you have a more complicated colonoscopy, you're going to need to get it in a different setting. I think we could grow some more of that opportunity in Vermont, but we'd have to think about, it has to be around population centers. I'm pretty confident those 30 in New Hampshire, where enough people have commercial insurance to make them viable. So in Vermont, I think we have to figure out how to figure out some lower cost options within the hospital systems that we have. I don't think you're going to see even 15 outpatient surgery centers in Vermont. I just think we're too rural. I bet there's not many in northern New Hampshire. Think Littleton, Colebrook, up that way.
But you think we can expand them?
I think we can provide more options for cheaper colonoscopies and outpatient surgery with almost what we have, repurposing some of what we're doing.
All right. You and I have talked in the past how a surprisingly large part of your budget at the hospital is prescription drugs. I know it's complicated, but we're talking about zillions of dollars every year. We pay the highest prices in the world for prescription drugs. You're dealing with the pharmaceutical industry that makes tens and tens of billions a year, ripping off the American people. I have not been impressed, either in the state of Vermont or in this country, why hospitals who have such mass purchasing power are not taking on the drug companies and say, you're not going to rip us off anymore. Why are we not doing a better job lowering the cost of prescription drugs?
Yeah, so first off, there are prescription drugs that are true miracles that are saving people's life every day. There's many more coming out. We have many new drugs now that for certain kinds of cancer are saving people that even 3 or 4 years ago we couldn't save, but they're exorbitantly expensive. And so the question is, why aren't hospitals doing more to keep those costs down? And so I can tell you that UVM Medical Center is part of what's called a group purchasing organization. We partner with a whole bunch of other academic medical centers to try and buy our drugs as cheap as possible. And we get a little discount, but nothing like the discount that Canada's getting, or Germany's getting, or many places in Europe. I just don't think that even like the academic medical centers, you put us all together, we're big, we're still pretty tiny compared to the power of those companies. And so I think if it doesn't happen at the national level, where the national purchases the drugs and controls the cost, I just don't think it's going to work. I think it has to happen nationally.
I think you could be not just you. I mean, you're a relatively small hospital, but I think if the hospitals of this country stood up and say the American people are sick and tired of getting ripped off, you would have a lot of support among the American people, and I just don't see the hospitals doing that. And I would appreciate you playing a stronger role in that if you could.
Thank you. I can.
All right. Let me touch on another issue that is widely discussed in Vermont, and that is the level of administrative costs and executive pay. My understanding is that UVM Medical Center's administration and management costs are something like 30% higher compared with similar institutions nationwide, including our neighbors in Maine and New Hampshire. I think I can speak for everybody in this room and say that Vermonters want their healthcare dollars to go to doctors, nurses, and medicine, not into bureaucracy. All right, so what are you going to do to keep administrative costs down? Will you commit to making administrative spending publicly available so Vermonters know what you are spending for non-clinical staff at the hospital and throughout your network?
Yes, so we actually do that now. All of our spending is on the forms we submit every single year to the Green Mountain Care Board, and because we're a nonprofit, we have to submit those to the federal government. Every dollar we spend every year can be accounted for, and it's available to all of you if you Google it.
That's all the salaries and all the administrators?
So for the administration, the top 5 or 10, the highest salaries every year are in the 990.
But you got a lot of guys underneath that, don't you?
I do want to say that administration is more than just the executives. Administration's everyone that's not providing care. So it's our people that are doing quality assurance, it's our people that are doing billing, regulatory, safety, it's people that are cleaning the rooms. Administration accounts for many things. Can it be better? Yes. One of the reasons that systems try to come together is to try and control as much of that, what I call back-end expense as possible. And we recognized that we were heavy on administration last fall, and we made a bunch of changes. So we eliminated a lot of leadership for the network in September and October.
Do you have more to do?
We probably have some more to do.
Okay. The general, and it's not just the hospital, I think it's UVM itself. I mean, we've talked about this for decades. Am I right on that? That it is very top-heavy with bureaucracy. So I think there would be a willingness to see you take action there and continue what you're doing. Here's another issue that is on, I think, people's minds. UVM Health owns several hospitals, 3 hospitals in New York State. And I think nobody here is suggesting that we turn our backs on the healthcare needs of our neighbors across the lake. But at the same time, it is my understanding that UVM Health, your organization, has loaned somewhere around $100 million to keep the New York hospitals afloat. A good argument can be made, I think an honest argument, that Albany has more financial resources than Montpelier does. So the question, Steve, is should UVM be owning hospitals in New York? And at the very least, when is that $100 million loan going to be paid back to Vermonters?
Yeah, so once again, I've been an emergency medicine doctor in Burlington, Vermont for my entire career, and I've seen many, many patients, and patients don't consider the lake a barrier to getting care. People who need to get care come to get care where they need it. And so over my career, we've taken care of many people from upstate New York who need academic medicine. I want everyone in here to know that our academic medical center couldn't survive. We wouldn't have enough patients if we only took care of people in Chittenden County and Vermont. We need patients from New York to keep our NICU viable, our trauma center, heart surgery, cancer care. Some of the big things that make us an academic medical center need more patients than we see only from Vermont. Those services benefit, and all of us benefit, from having upstate New York people come across the lake and get care at the academic medical center. That's how we have enough doctors to provide that care and see enough patients. And in many ways, it actually helps control the cost, because if we tried to say we're going to stay in an academic medical center and we just won't worry about New York, the cost per patient would have to go up to pay those doctors and keep those services running. Now, I know people will say, well, you don't have to have Plattsburgh Hospital be part of your system. Those patients are still going to come here. I want you to hear from me. That is not true. Albany wants those patients. Rochester wants those patients. Academic medical centers need those patients. NICU children, sick trauma patients, cancer care, and those patients would go not to Vermont. So from my perspective, I want to have a strong academic medical center so that when I or my family or any of you or your families need that care, it's available here in Burlington and we can get it here. We need to be able to attract specialist doctors that are going to see enough patients to keep their practices viable. We need upstate New York patients to come to us, and Plattsburgh Hospital being part of our system really helps that. The flip side is also true. If CVPH Plattsburgh suddenly became weaker and was a small hospital, say they kind of became a critical access hospital, those patients would still come across the lake to get care. They can get here, there's a ferry, they could get here or the bridge, and we'd be overwhelmed by those patients coming in. Access would be even harder, and I know we're going to talk about access. So it is in our best interest, all of us in here tonight and all of Vermont, to have CVPH be a strong, viable hospital. And we're working hard on that. It is true that we've had to support them some significantly through the pandemic, and here's the answer. We have to get them so they are making budget every month, earning a margin, and we're close on that. We're going to get there. The strength of the network is starting to pay off over there. They're doing better. They had a very good December. And so the future, I strongly believe that all of our Newark hospitals will be self-sustaining, and they'll be able to slowly pay us back the money that we loaned them during the pandemic to keep them viable and keep our academic mission going over the past 5 years.
Let's say a word about Medicare. It is my understanding that you guys are losing somewhere around $100 million each year on Medicare, while Dartmouth Hitchcock and Albany Medical Center lose about 10% of that, somewhere between 10 and 12 million. And while we have a lot of older folks in our state, they are by and large healthier and actually use less services than people in New Hampshire and Maine. How can UVM Health get its Medicare spending in line so you're losing less and shifting less of the costs to private insurance?
It's a great question. We have set a 5-year goal for ourselves to get to break even on Medicare on as many things as we do as possible. It'll never be all of them, okay? We are learning from other places that are doing it extremely well. We meet regularly with Dartmouth and Maine Health. We just had a meeting with them to try and understand some of the things that they are doing. And so we have to figure out how to control our expenses better. It's expense control that'll help us get there, and it's really hard work. Expense control is not easy, but we are committed that over the next 5 years, I won't say everything will ever be at Medicare, but we'll have many more. it's critical for our survival because as more Vermonters reach Medicare age, the cost shift gets harder and harder. So we are focused on that right now.
And you think you're going to make some progress in the next 5 years?
We're already making progress.
All right, we've touched on some of the issues that you have direct control over. I want to go to areas which in some sense, one sense, is outside of your purview, but as the leader of healthcare in Vermont, and by the way, tonight, I'm proud to make you the healthcare czar of the state of Vermont. You're it. For better or worse, you're it. So there are some areas that go beyond UVM Health, and let me give you an example. No great secret that nationally and in the state of Vermont, we have a serious crisis in healthcare workforce. We don't have enough doctors. People wait a long period of time, right, before you can get to see a doctor. We have a major nursing crisis. The estimate that I have seen is that in the next 2 years, we need some 5,400 new nurses in Vermont alone. Nurses are needed not only in hospitals, they are in nursing homes, they're in home health care, they are in schools, they're in primary care settings, FQHC, all over the state. We got a major crisis in terms of healthcare workforce, all right? What leadership role are you going to take to expand the number of nurses and doctors and others? Now, by the way, a couple of years ago, Steve and I were chatting, and he told me something that really blew my mind, and it just talks about the irrationality and dysfunctionality of the current system. And Steve, you correct me if I'm wrong, but my memory is you told me during COVID, and COVID was obviously an exceptional moment, UVM spent $125 million in 1 year on traveling nurses. $125 million. Traveling nurses at that point were getting salaries substantially higher than our local nurses, okay? Is that correct?
That's correct.
Okay. So my question to you, I think what we all know, nobody is prejudiced against traveling nurses, they have a job to do. But common sense suggests that we would love to have young people in the state of Vermont go to nursing school, get the education they need, come back and work here in our healthcare facilities. Common sense suggests that when we have an aging doctors population, you're one of the younger doctors in Vermont.
I wish that was true.
But that we need a lot more doctors. The UVM Medical School, very fine institution, graduates about, I think, 112, 115 doctors a year. Some of them stay, many of them go. So how do we grow the number of doctors in Vermont? And I'm working on this nationally as well. How do we get them into rural areas? What are you going to do about that?
So part of it is what we just talked about, our academic medical center. Without our academic medical center, without having enough patients there, we wouldn't have a medical school. And the medical school is a steady supply of people who come to Vermont. Some are lucky and grew up in Vermont like me and go to medical school here and get to stay and spend your career. But we have a lot of other people come and find out how great Vermont is and choose to stay here. About 30% of the residents that we graduate from the residencies at the hospital end up staying somewhere in Vermont. Not all just in UVM Health or Chittenden County. They stay and go to Newport, St. Johnsbury, Brattleboro, Rutland. There's doctors that trained here at all those sites. Is it enough? No. But imagine how much worse it would be if we didn't have a way to train those people here and show them the greatness of Vermont. The real challenge for doctors and for nurses in Vermont, and actually for most of the people we're training in healthcare, is not so much the training in the classroom. We can do that, and the medical school could definitely have more students in the classroom, and so could the nursing school. We don't have enough clinical sites to train all the people, learners, that they need to have enough exposure. So right now at the medical center, we're taking about as many learners as we can. Respiratory therapy, nursing, medical students, residents, I'm missing a bunch, x-ray techs. We're training about as many as we can, and we're spreading out more into UVM Health across the system, but that will not be enough. We have to figure out how to get more learners out to all of our other hospitals, FQHCs, private practices. When I went to medical school here, I actually went and did a primary care rotation in Brandon, Vermont, which was close to where I grew up. and had a great experience. And actually, the most interesting part about that is the doctor there was paying off his student loans, and he asked me to do a night with him at Porter Hospital in the emergency department. And when I did that the first night I did, I came home and told my future wife, I said, I'm going to be an ER doctor. That's what I want to do, from Porter ER. And so getting our students and residents and learners out across the state will fill in those spots like it does with the fellows. We have to come up with more clinical sites. And that's not something you can do just with simulation or watching a video. They have to be at the bedside, seeing patients and understanding what the instructor is giving them. So I do think there's a lot of opportunity to grow that in Vermont. It was better a long time ago. It's gotten worse. We have to figure out how to bring that back.
We are working in Washington on a concept called teaching health centers, and I think God knows what's going to happen in DC next week because of this ICE situation. But with luck, we're going to expand significantly the amount of money going to teaching health centers, which will help residents be able to get the training they need in non-hospital facilities.
Yeah, so the teaching health centers is amazing. Vermont, how many FQHCs are in Vermont? There's
13, I think. How many? 11? With 90 sites and some 200,000 patients.
So once again, I think most of them could be teaching health sites. That'd be a great place for learners to go and get great exposure, and then very possibly want to go practice there afterwards.
But is that something you're going to focus on?
We can work on that. I have a meeting with the FQHCs, I think, in 2 weeks.
Good. All right, the point that I have made to Steve privately and make it publicly, he is, head of a major healthcare institution in the state of Vermont, but he's got to be much more than that. He's got to be working hand in glove with hospitals all over the state, with the FQHCs, private practices, et cetera, et cetera. That's what your job really is.
Yeah, I'll just say, I'm completely committed to improving the healthcare of all Vermonters across the entire state and partnering with all healthcare providers and systems to try and make it better for everyone we serve.
All right, one of the as part of that, and Steve, correct me if you think I'm wrong on this. If I have the flu, a non-emergency situation, and I know sometimes what is emergency is not, if I have a pain in my chest, it's an emergency, right? It may not be, but to me it is. But on the other hand, if I have a cold, it's not an emergency.
Usually.
All right, right. But there are many people in the state who go to emergency rooms for their primary care. My understanding is that care is about 10 times more than at a community health center. All right? So what are we doing now to make sure that people are not getting primary care in an emergency room when we can be saving substantial sums of money and better health care by finding them a medical home?
That really comes down to access. So if you look at our federally qualified health centers and most of our small private practices, we just talked about it in the back. You were telling me about one, I won't name it, but has one doctor. Can they really be open every weekend? Can they be open evening hours? Are they open tonight? And so if you're not feeling well tonight and you have a cold and you're sick and maybe you have to work tomorrow and you can't see your doctor in your primary care office because there's one, where are you going to go? You're going to go where you get to get in, right? And so we have to figure out ways to improve access to those small clinics. I think telehealth can help. I think maybe we can help with some outreach and maybe provide some more support to them in certain ways. But we have to have better access in our rural communities, because if we don't, people will do what's rational for them, and what's rational is to get care tonight if you have to work tomorrow.
But on the other hand, I agree, but what's also rational is that in the richest country in the history of the world, people in the state of Vermont should be able to walk into a medical facility in their community and get the health care that they need.
Totally agree.
All right, the healthcare crises that we're talking about is not only the cost, and it is not only, it has a lot to do with access, and it's not just primary health care. I'll never forget this. Just a few months ago here in Burlington, I had a town meeting with some seniors. Some guy gets up and he says, I said, tell me about nursing homes. We study it. I'm the ranking member of the health committee, used to be the chairman, so we study these things around the country and in Vermont. I'll never forget this. This guy gets up and he said, let me tell you a story about nursing homes. My sister-in-law was very ill. She went in a nursing home. And she said to me that if ever again I have to be placed in a nursing home like that, kill me. I don't want to do that again. All right, now that's pretty dramatic. But I think it is no secret that we have a crisis, that there are many people in the state who have parents who are old, who need nursing home care. They can't find a bed. We have seen the closing down of a number of nursing homes over the years. Nursing homes are understaffed. In some cases, we have seen studies, it's horrible. They don't even provide the quality food that people in nursing homes need. All right, Steve, I know it's not per se, your job, but I'm asking you to take over that responsibility. What are we going to do to make sure that when people end up in a nursing home, there are beds available and they get treated with the respect and dignity they deserve?
Nursing home care is a huge challenge right now, and once again, I think Vermont's in some ways leading the way because Vermont is older, and so we have more people who need nursing home beds. Nursing home care became a huge crisis during the pandemic. We did a lot of stuff really well, but we lost a lot of nursing home beds during the pandemic, and so we at times at UVM Medical Center had 80 people waiting to go to nursing home beds. That was really taking up a lot of bed space.
And spending thousands of dollars a day per person.
So I think there are some amazingly great nursing homes in Vermont. And I think there are some that have challenges with staffing and making sure they have enough people there every night. And so we need good reimbursement for nursing home care. We actually have partnered with a couple local nursing homes that are not part of UVM Health to have good relationships with them. We're supplying some medical direction, which is oftentimes very challenging for them. And I think working with the state of Vermont, we have to figure out how to get a little better reimbursement. They're not reimbursed well, which is an issue to work through. And I am going to say this because you call me the healthcare czar, but I want to make sure everyone in here hears this. No one person is going to solve the healthcare crisis in Vermont, but here's why I'm encouraged. Because you guys all came out tonight in a snowy, cold night, and in this room right now, we have healthcare leaders, we have regulators, I see a couple of them, we have other doctors in here, we have nursing leadership in the unions here, we have local Vermont legislators here. Together, like the pandemic, we can solve it. So, I don't know if you want to call me the czar or not, but it's going to take everybody. UVM Health will do our part. I will lead us on our part, but it's going to take all of us together.
You're absolutely right, but not only do we have to work together, we have to really take on a broken system. The status quo just is not working. You know, I mentioned, the insanities, the irrationalities of spending, it was true all over the country, huge amounts of money on traveling nurses because we're not educating our own. All right, let me get back to the nursing issue, because it's an issue that I've worked on. If you can believe this, to the best of my knowledge, this is what I understand, we have young people. Being a nurse is just a hugely important profession. And we have people who want to be nurses. And yet, we don't have, if you can believe it, enough nurse educators. So if I am a nurse with a master's degree or a PhD, I work for you at the hospital as a supervisor, I'm going to make a pretty good salary. If I work at the nursing school as a teacher, I may literally make half that salary. That's pretty crazy. What are you going to do to make sure that as we grow the number of nurses, you have the nurse educators who are able to handle an influx of students?
Yeah, so I'm really happy to tell you that with some federal support and some grants, we got a program where we were able to just graduate our first group of 31 nurses who are either getting a bachelor in nursing or a master's. And then as part of that program, their schooling was paid for, the time to get trained was paid for, and now they've committed over the next 3 years to train UVM students. I actually rounded last week on one of our floors and saw one of the new Masters of Nursing leaders teaching 4 UVM students, which is 4 new people who weren't getting trained before, and that nurse is getting increased wages for that. So there are programs that can help this, and that was a bunch of different groups coming together to bring that funding together, and it was great for the nurse, really great for the
students. You're going to need 5,000 nurses in the next 2 years. Doesn't sound to me 4 nurses are doing it.
31 is not enough, But it's a start. The program does work.
All right, are you working with the State University, with the community colleges, Norwich?
We are working to make sure, so a lot of these nurses are, in fact, I think all these nurses were trained through Norwich, I think, for their masters. I think that's what she told me.
All right, but we've got to bring all, you mentioned it a moment ago, we've got to work together. We've got to bring all the nursing schools together. We've got to figure out how we can maybe provide incentives to young people that they stay in Vermont. We'll pay for their tuition, right? All right. But the bottom line is it improves health care and it saves us money when we have a strong number of Vermont nurses in this state. All right, but it's not only a nursing crisis per se. We have a home health care, right? So you got working people. They got to work every day. They got a mom and dad who needs help, somebody to come into the house. The pay is atrocious. It's a national problem. What are we going to do to get people into home health care so that somebody can go out and work and earn a living and not have to stay home, take care of a mom or dad?
Another huge issue, I don't have all the answers. I can tell you that as part of UVM Health, we do have home health and hospice as part of that, and we have a strong program with the medical center with them to make sure they have enough nurses to be able to take care of people that are ready for discharge who don't need a nursing home, but VNA support or a home health aide can help them. You're going to tell me it's not enough because it's true, but we have to grow programs like that because getting those people out of the hospital actually is good for the hospital. It saves us money. Being in their homes is better for them and prevents complications, and so we have to figure out ways to grow those programs.
I think you and I, maybe some years ago, had talked about the absurdity. I hope the situation is corrected, but literally, you have people on Medicaid coming and getting surgery at the hospital, good surgery, then they go home to a cold apartment where they don't have enough food, and then lo and behold, 3 days later, they end up in the hospital again. Is that true?
That is true.
All right. So that's an area that we've got to focus on. That makes no sense to anybody. It's a waste of money and it's a waste of human, it's human suffering that's unnecessary.
That's a sick care system instead of a health care system.
And that's what you're going to change, yeah? All right. And the last question I want to raise to Steve, and then we'll open it up, is a very painful one, and it bothers me personally, and I deal with it every single day. You got a broken healthcare system, 85 million uninsured or underinsured. People can't afford to go to the doctor. And we have an administration in Washington that has done two disastrous things. Number one, they've cut back on ACA tax credits, Affordable Care Act tax credits, which means that on average, people in the ACA are going to see a doubling of their premiums. Some people will see a tripling of their premiums. Some people actually will see a quadrupling of their premiums, and they can't afford it. So either they will spend money on health care and cut back on the basic necessities of life, or more likely they'll stop getting the health care that they need. And then on top of that, the Trump administration has decided that in order to give $1 trillion in tax breaks to the top 1%, they're going to pay for that by throwing 15 million people off of Medicaid. You add that up in Vermont, we're talking, as I understand it, about 45,000 Vermonters between ACA and Medicaid are going to lose their health insurance. So we've got a crisis in the state right now, and unless we change it, and by the way, because this is so unpopular, that we have a chance. I would not like to be a Republican congressman going home and explaining why I cast that vote. So we have a chance to turn it around, but if we don't, Steve, if that disaster takes place and a bad situation becomes even worse, how are we going to handle that?
So that's a huge problem. I saw data that said, as of last week, about 10% less people have signed up for healthcare on the exchange than last year. That's just the first look at that, so I'm sure that's less than is true. That'll be a big problem, because all those people, just because they didn't sign up doesn't mean they won't need healthcare in 26. It just means they don't have insurance to pay for it. So we're looking right now, we're trying to study if there's ways we can offer some low-cost options for lab testing, imaging, maybe simple test sites. We're working on a program we could do that. I think we have to figure out other options in Vermont to have people get low-cost care. I can tell you at UVM Medical Center, we do have really strong financial aid programs for people who are underinsured or don't have the ability to pay for their medications or services. But it's going to be a huge problem for the state of Vermont and for all those people who now are going uninsured. So we're going to try and work on pieces that we can make it a little better, but I want to make sure you hear that it's going to be hardship for many people.
Okay. All right, let's go get some, we've got a mic over there, and we got a mic over there. Just give us your name and where you're from, if you could.
Hi, how are you doing? So
Your name is?
Professor Janet Benyon,
Hi.
and I work at Vermont State University, and I think you should be aware of the 3 new nursing programs that we sponsor. I've got at least 20 nursing students in my anthropology classes, and I want you to know that we have clinical affiliates, and when you're talking about Norwich and UVM for training nurses, we've got Vermont State University working at this, and we're really doing a great job.
All
And
right,
people need to know about it.
Are these guys working with you as effectively as they should?
I think that they should work more thoroughly, and what we need is funding for better teachers.
That's what I was talking
We
about,
have
right?
not got enough funding to pay for the nurses, the nurse instructors, to take care of the massive amount of student applications and students in the class now. So
All right.
we need some funding at
All
Vermont
right.
State University to
All
take
right,
care of
but
the
it's not-
nursing
look,
crisis.
Look, my thought is, I'm aware of that, and also we're trying to bring in some money to the community colleges as well. All right, but keep the mic. The area here is, I know Castleton is the major.
Yeah, I got switched from Johnson to Castleton, and I was at Linden. I introduced you once.
Okay. But, so we got Castleton, you got Norwich, we got UVM. Those are our 3 nursing schools. We got to figure out a way how we work together. Her point is how we pay educators, we talked about it, the salaries that you need, how we bring in young people into the
Yeah,
enormously
and you
important.
spoke about grants. We're not aware of any connection with that, so work with us.
All right, Steve, will you sit down with the nursing schools and make sure that they're coordinating?
Yes, we work that.
Okay, thank you.
Hi, David Lewis,
Hold the mic close to your mouth, please.
like that?
Yeah.
There we go, now I can hear myself. I was an actual patient at UVM recently. Wonderful care, double bypass. I'm still here, everything works. What I kind of want to do is, because Bernie, I feel like you're picking on my new boss, is I had a wonderful nurse. He was with me for about 2 days, and he loved everything about Vermont. He had his own RV, he had his own trailer, all kinds of stuff. The reason he couldn't stay was he had nowhere to live. So I know this is another Vermont problem, but I kind of want to, this is the issue on why we can't get nurses and why we can't keep the
Right.
travelers once they fall in love with us, is because there's nowhere for them to stay.
Okay, excellent point. It's nurses, it's cops, it's firefighters, it's teachers. We have a major housing crisis in the state of Vermont and throughout this country. And your point is absolutely right. Steve, what is, again, this is a statewide problem, but actually you're doing some work, I know, at UVM. Why don't you talk about that?
So we do have some housing, and it's specifically set up for people that are moving here who want to get settled, get in housing, and so I would encourage people who work at UVM Health anywhere. We have, I think it's 160 or 170 apartments. Some of them have income control on them, and so they're work pretty well. It's not perfect, it's not the whole solution, but we have some. I think we're working on some in Montpelier right now as well.
Thank you for that very good question. Sir?
Thank you. My name is Steve August. I'm from Montpelier. Senator Sanders tonight raised at least a dozen huge issues in the healthcare area. And the answer, you did the best you could, but it seems like you're saying, yeah, that's a huge problem. We got to work on that. I feel like we're rearranging deck chairs on the Titanic. People are suffering right now, today. They're not suffering in 10 years. How are we going to turn this ship around when we're facing a serious disaster? I'm concerned about that.
Thank you. So I hope you didn't hear me just say, yeah, that's a problem. Remember what we just heard over here. People are getting great care. How we afford the care, access to care is a real problem. I do think Vermont, by working together, by UVM Health helping have more doctors at sites outside of UVM Health, at the other hospitals, maybe at FQHCs, can help. That's a lower cost site of care. I do think we can figure out how to train more learners so they want to stay here. I think there's a lot of steps we can take together to make the good care we deliver be more affordable and more available. And also, and this is really important to hear this, what we really need is Vermonters to be a little healthier. We all have to figure it, no, it's true. How we're really going to save money is bring down utilization, because I told you, I think in the beginning of this, that our premiums for Blue Cross are going down about 12%. But if more people need Blue Cross care this year, more people come to the hospital, Blue Cross's premiums won't go down at all. Their premium is based on what it costs per service and how much service people have to get. So this goes all the way back to where Bernie started. We have to figure out how to have people be a little healthier. All of us, we have to do the right things to be a little healthier. That's actually how we're going to save money. And so how can we have better access to primary care? How can we have better access to good, healthy food? How can we have people have a warm place to stay tonight? That actually will make a big, big difference.
I would just add to your question. You're right. In many ways, they are rearranging the deck chairs on the Titanic. What I have seen, and again, I've been all over the country, people know the system is broken. But what we have got to do, this is not really a healthcare problem. This is basically a political problem. Right. It is that you have drug companies who bribe members of Congress every day, just huge campaign contributions. Insurance companies with enormous power put money into super PACs. So the answer to your question, we're going to do the best we can, and I'm going to be working with Steve as best I can. But at the end of the day, it amazes me. Like 70 years ago in Canada, they started in one province, Saskatchewan actually, and they said healthcare is a human right. Is their system perfect? No. But they spend about half as much as we do per person, and when you end up in the hospital for a month, you don't pay a nickel because it's publicly funded. That's the job. That's the goal that we have. That's part of a progressive political movement that takes on the drug companies and the insurance companies and their greed. The system is working very, very well for them, not for you, not for us. And that's a political revolution that we need, and I hope all of us make sure that that happens.
Thank you. My name is Victor Rodwin. I'm from Montpelier. Thank you so much for these great questions and very good answers under the circumstances, Dr. Leffler. I've had great service at your hospital, our hospital, but I was shocked to learn that Leapfrog gave the UVM Medical Center a very, very low score. It flunked on quality, and that's the best hospital in Vermont. And all the hospitals, all 14, got terrible scores on quality. We haven't talked enough about quality. Now, how do you explain that? As a university, I understand that small hospitals would get low scores just in terms of statistics. But Dartmouth got a reasonably good score, and UVM seems to me to be as good as Dartmouth, anecdotally. What's going on here?
Thank you so much for asking. So, specifically to Leapfrog, the way Leapfrog works is they are a company. They're a private company. And they send every year a survey to the medical center, and they say, would you like to participate in Leapfrog? And if you want to, you pay them money to participate. And we've chosen not to pay the money, and so they only take a certain small set of our data. And many hospitals do choose to pay. I don't think a single hospital in Vermont right now is actually paying Leapfrog. And so they take just a slice of what we do. We are very, very focused on quality at UVM Medical Center right now. We have some more current data that we could share. What I would say about Leapfrog is they're a business, and we've made the decision that we're not going to spend the money on that right now. And we think about it every single year, and every year we say, we don't think it's going to actually add value.
Please, hi.
Hi, thank you for being here. My name is Dr. Jennifer Simpson. I own a small independent physical therapy clinic in Winooski, and I'm also the Federal Affairs Liaison for the Vermont chapter of the American Physical Therapy Association. And so I'm a military spouse, so I have TRICARE healthcare. And prior to moving to Vermont, I was the chief of physical therapy for the Warriors in Transition Battalion in Hawaii for several years. So I've experienced working under and being insured in a US government-run healthcare. And overall, I'm a big fan of the universal coverage in the ways that I've experienced it. The emphasis is on promoting health and the fastest and most effective treatments, not profits or shareholders. So my question and concern today, though, is about expanding Medicare as it exists today, between budget neutrality, where if we want to pay primary care more, we have to take it from somebody else, the discounting of multiple codes. So if you come to see me, the first 15 minutes of exercise are paid at a certain percentage. Every additional 15 minutes is less money. And it's actually, we're paid 20% less in dollars than 20 years ago. Not just not keeping up with inflation, literally $20 less per visit, or 20% less, I mean. So independent providers just can't exist on Medicare reimbursement. Like Dr. Leffler said, we rely on higher commercial payments to subsidize to remain open to even provide the quarter the amount that UVM gets paid for the same physical therapy appointment. 25% is what we get paid versus the hospital by Blue Cross Blue Shield. And so in order to sustain seeing Medicare patients, seeing Medicaid patients, we're kind of at a loss. So our concern is, how do you see Medicare evolving to actually pay providers enough to attract new providers, especially to rural areas, or to keep the ones that we have if we're all to shift to Medicare for all? Because physicians can't stay open, PT practices, nobody can stay open if all of a sudden Medicare reimbursement is all that's offered to all providers.
Look. Steve, you want to jump in?
I was hoping you were going to take this one.
I will. All right. I mean, one of the many insanities and dysfunctionalities of the current system is we spend an enormous amount of money on administration and paperwork, right? That's what you're talking about. It's not just you, it's the person at the other end, the patient is also filling out forms and arguing with the insurance companies. Steve, do you have any rough idea how much money and time and energy at the hospital goes on arguing with insurance companies regarding coverage?
We have a huge group, I think it's more than 30 people whose time is spent putting in claims and then updating the claims and back and forth with insurance. It's a big group of people. It's very expensive.
And one of the reasons that we spend twice as much per person compared to Canadians, and maybe 3 times more than the British, is they have made the decision that you're not going to have to fill out all the forms. People are not going to fill out the forms. You're not going to have to. People walk into the office, and your job is to provide care to them. And that's what Medicare for All is. So Medicare for All is a 4-year transition period. The first year, it includes dental care, hearing, and vision. It lowers the eligibility age to 55 and includes all children. Following year, down to 45, then down to 35, and it includes programs like physical therapy and massage therapy and many holistic therapies. Does that make sense to you?
It does. Follow-up, though, the biggest lobby, for the most part, is the healthcare insurance companies.
Yeah.
Is there some sort of plan to turn it into like TRICARE, where it's regional, where Blue Cross and MVP gets New York and New England, and Kaiser gets California, and the government just pays them to administrate? Because there's not a chance they're giving up what they were given in the Reagan and the pre-Reagan era without a ginormous fight.
The answer is there are plans, yes, and we can talk about it privately at some point.
Thank you.
Okay. Ma'am?
Hi. First, thank you both for being here. I think this is a wonderful event. A little background, I am a native Vermonter like you, Dr. Leffler. I am also a nurse, and I've had a varied amount of experience. I started as a nurse assistant, and then worked my way up through. I have done everything from work in the C box at the VA up through critical care medicine at UVM. And I can tell you, as a traveler as well, there is no better place than UVM to get training and to get health care previously. However, I do think it has declined, and there are many factors contributing to this. But I will say that I have traveled all over as a nurse, and the people work together better. We don't have like I'm a doctor, so I'm not gonna help you with that patient. They're willing to help you. I had tremendous experiences with all of the physicians who let me shadow them and follow them and work with them, and it's just a fantastic environment overall. However, with my experience, I have also come to leave the field. I was taught early on in nursing school that the future of medicine was prevention, and it was community health care, and that was supposed to be the focus. So we all got tremendous training in that, and all I've seen since then is a shift to a business model of medicine. And like you said, it's sick care, it's not health care. We're not teaching people what to know about their own bodies. I have a mother who has no clue what's happening with her body, and I have to educate her regularly. I have a little daughter who I have to teach about her body, and I've taken care of several family members who've been failed by our system over and over again. And I feel that this is because we lost sight of community health care and preventive medicine, and I'm wondering, what is your plan to try to reignite that focus? And I do have a second comment, if I may, once you're done with that question.
Yeah, so we are opening up more primary care spots across our system. We're doing that by using our electronic medical record to help with better scheduling. We've opened up almost, I think, 3,000 spots over the past year by better scheduling, and we've added some doctors. We have some more doctors coming on. It's still, the demand still keeps outstripping what we are adding, but we are hard at work on adding primary care, which I think is who really does prevention the best right now, and so we're hard at work on that. Thank you.
So
I think if I could add to your point, I mean, again, the irrationality of the system. Turn on TV today and you're going to see ads for kids to eat crap food full of sugar. We end up with the highest obesity rate in the world, right? Diabetes, other diseases. So as a nation, you know, we have got to do a hell of a lot better in keeping our people healthy. Did you have a quick follow-up?
Yes, in terms of, you both spoke about the need for new doctors, new nurses, and I do feel from a personal level, the other problem is that we've overcomplicated everything. We focus too much on all these nurses need a bachelor's degree, then they need a master's degree, then they need a doctorate degree, and then we hire too many of them to become clinical educators and nurse managers and assistant managers, and there's way too many administrative people in the hospital. We need people to take care of the patients in the community and in the hospital, and we need it to not be so hard. I had a clinical instructor who was fantastic, but she had to stop because she wasn't willing to go back to school to get a master's degree. I also believe that my best educator in surgical critical care was a person who had a diploma nurse, and she learned on the job. She was teaching the residents how to take care of patients. She was teaching them about ventilation. She was teaching them about cabbages and how to come off of these ventilators, and she was the best teacher. And at Dartmouth, I worked there as well, and they were getting rid of these staff just because they didn't go back
Steve,
to get a master's.
that's an important issue.
Yeah, so
They're the best teachers there are.
yeah, so in general, I agree with you, and one of the things we're working on right now, and I've been saying this a lot, is we need more doers and less leaders, and so we're focused on that right now. Thank you.
Okay, ma'am.
Hi, I'm Colleen, and I live here in Burlington. And as a brand new nurse, a couple decades ago, my parents would say, "How much is this procedure going to cost me?" And now, a few decades later, as a nurse and as a mother and as a person who gets health care, I think, why don't we know? The hospitals have agreements with every healthcare insurance company for every tier of care. There are more complex things in the world that are more transparent. Why can't we make a website, make a system where we let people know what the costs are?
Okay. Steve?
Thank you. So I believe on our website, I haven't tested it myself recently, but we do have some cost estimates, and our financial advisors can give you an estimate of what things should cost.
I mean more like you're going to get your car fixed, you're going to the vet. I want something like I can put in my health insurance. I know if I've paid my deductible this year or not. I need to go get labs. I can put in and look on a website that doesn't have a barrier. I want no barriers for anybody.
You want to know what the procedure is going to cost you?
I want everything's going to cost.
Okay. All right, there is a big move, I should tell you, in Washington, I think probably on the verge of passing legislation that moves in the direction of transparency, which is what you're talking about. Okay. Okay, ma'am.
Hi, I'm
Hey, Ellen.
Ellen. Thank you so much for this meeting. Bernie, you mentioned that we need a political revolution, and you mentioned Saskatchewan. We have a chance in Vermont to be Saskatchewan. There's a bill called H433. It would phase in universal publicly financed health care, but beginning with universal primary care. It's very cheap. It's under 6% of all of our health care spending. It would make primary care a universal, publicly financed public good. That would be good for Vermonters. It will keep people out of the emergency room. It was the single thing you can do to make a population more healthy. And so my question is, Dr. Leffler, if they take H433 off the wall of House Health, because we've got to think about Vermont, right? With all due respect, DC's not doing too well right now. So, if H433 comes off the wall of House Health in the Vermont legislature, will you, Dr. Leffler, not stand in the way? Thank you for answering my question.
So I'd want to understand where the money's going to come from. Okay, you're going to tell us?
Yes. Okay. The money would be raised publicly, but keep in mind that once we pay for any sector of our health care as a public good, then we can't be double charged. That is, an insurance company can't charge you for a service that becomes a public good, just like the roads, right, and the schools. So the idea, and keep in mind, very cheap, under 6% of total healthcare spending. So it'd be a great way to phase this in. You know, Bernie, when you were running for president, I wish you'd been president, but people used to say, well, how come they haven't done this in Vermont? This would be a way of starting with a relatively small but very impactful service. And I do want to make clear, and we should all know this, 187,000 Vermonters are underinsured. That means even if they have health insurance, they don't go to see their doctor because of out-of-pocket costs. They end up, every doctor will tell you this, I'm not a doctor, but doctors tell me this, you will end up getting sicker and waiting, and then you end up in the emergency room. And finally, I'll just say, the Oliver Wyman report said we would save $300 million if we made primary care universal.
Steve, what I would suggest, I know Ellen and I know Deb right behind her, and they've been working on this issue for years. I would appreciate if you sat down with them. You know, it's hard in a meeting like this to get all the facts. But I think Ellen's point is well taken, which I think you would not disagree with, that if everybody in the state has access to primary health care, in the long run, we save money, we improve health. Will you sit down and talk to these guys?
So yes, and so I want you to know I've met with VMS, who's sponsoring the bill. I've met with the representative from Madison, who's sponsoring the bill. We've started the discussion. There's a lot of detail we need to understand. And so I think that's where we're at right now, understanding it better.
All right, but you sound like a politician. All right. All right, but...
We would love to sit down with you.
All right. These things are complicated. I know that, and you can't make decisions right here. But I would like you to sit down with these guys. Is that something you could do? All right, Ellen, Deb, give them a ring? Okay.
Can I just give the follow-up to Ellen?
Yeah.
I know, I want to be fair. But, you know, you talked about getting, you know, money that's already...
Introduce yourself.
I'm sorry, I'm Deb Richter. I'm a family physician and addiction medicine specialist working on healthcare reform for years and years. But I wanted to make sure that, you know, people understand just a visual of, this was one family medicine practice I used to work in, 4 physicians, 2 nurse practitioners, who basically, I asked them once to print out an insurance list. This was all the different insurances that we had to bill. And I just want to show you an example of one practice of, you know, what that looks like.
I think we got the point. And this is why one of the reasons why healthcare in America is the most expensive in the world. People should not be spending their time filling out those forms. They should be treating patients.
That's $5,000 for every man, woman, and child in this country spent on administrative costs.
Right.
And this is the reason. With H433, we would have one insurer, essentially, or one payer, that would pay, at least for the primary care. And
Right.
then we'd add the other second.
Right. Okay.
Sorry for the...
All right. Steve, you'll sit down and talk about it. Okay, sir.
It's a tough act to follow. I'm a veteran. I get all my health care through the VA, and I can't say enough for them. They're great. I'm wondering why you don't support veterans care for all Americans. Because it's better than Medicare, because it's, for one thing, Medicare only covers 80%. The VA covers everything.
Well, as the former chairman of the Veterans Committee, I have spent years fighting to protect and expand VA healthcare. We're trying to get you, make sure dental care is available to all veterans as well, among other things. The point is, this, again, is not a healthcare issue. It is a political issue. There are people right now, you talk about expanding VA, there are people now who want to destroy the VA system, who want to privatize the VA system. You know why? Precisely because veterans in Vermont especially get good quality health care in a cost-effective way. That is a bad example compared to the private industry, all right? So right now, our fight, we're working with the VFW, the Legion, everybody else, is to make sure that we protect VA health. I can tell you, in this state, I don't know, we have many veterans here who use the VA health care? Good, does it work for you? Yeah. All right, generally speaking, no system is perfect. People feel very good about White River community-based outreach clinic here. So you're right, we want to expand it, but you should know that the big money interests do not want the government involved in healthcare.
For one thing, the VA is doing this whole health care program where they are helping us to learn how to eat properly.
That's right.
And how to exercise and everything. That
And we're ahead of the curve on things like acupuncture,
yes.
Yoga, and
Yes.
which reminds me, Steve, do you guys do much about in holistic medicine? Is that part of the...
We do. We have a chronic pain program. I see someone in line that's going to talk about it probably in a second. And we actually have one of the only contracts in the United States with our insurer, Blue Cross, that's a bundle payment for chronic pain that's shown huge savings, decreased ER utilization, improved quality of life scores, and it has a full spectrum of health benefits beyond just getting meds or just physical therapy, which are important. I'm not saying those aren't, but there's a lot of other stuff that we offer in that program that really is helping people.
And the VA and Department of Defense, ironically enough, people think they're conservative. They were way ahead of the loop on those issues. All right, let me go over here. Sir?
Liam Grima, doctoral student in Sustainable Development Policy at UVM. Just want to thank you, Senator Sanders. You're my intellectual inspiration and the reason that I'm here right now. But I just wanted to say a structurally consistent theme underlying all of the crises that are being addressed, in my estimation, is an overdependence on market institutions, meaning a veneration and worship of markets as if they are some divine artifact that naturally allocate resources more efficiently than any social institution that prioritizes public welfare over private profit. They prioritize exchange value over use value. They don't distinguish needs and wants. Right now, you're talking about the issue of Vermont, so I want to stay away from the national level. There's a bill that was just brilliantly laid out to move towards that kind of system. Senator Sanders, in your estimation, how much of the opposition to the bill in the state of Vermont is genuinely ideological versus an actual malign corporate influence campaign like we see on the national level? And Dr. Leffler, if you wouldn't just mind, if we do succeed, as I hope we do, moving towards this system, as we attempted to do a decade and a half ago in that experiment that was terminated prematurely, which was a devastation. It was projected to lower healthcare costs overall, private and public, by $1 billion over a 10-year period. would you be able to work within the confines of a universal healthcare system that's financed at the state level rather than the national level? Or do you think there would be too many practical hurdles to not having access to a national pool? Thank you very much.
The short answer to your question is obviously the corporate interests, the insurance, drug companies, and other entities spend huge amounts of money. At the state? Yeah, of course they do. They go to every state in the country. And by the way, they are fearful. They don't like the VA because VA provides good quality health care offered without any out-of-pocket expense. They don't like that. And they don't want to see any examples. What happens if Vermont had a system which was less expensive, better outcomes? That'd be the worst thing that the insurance companies would want. So yes, they're going to oppose that. Steve?
Thank you for your question. So first I want to make sure you know that UVM Health is a nonprofit. We have no shareholders. No one's making dollars at the end of the year on a dividend or something like that. All the dollars that we make, we reinvest back into the system. I will tell you that Vermont is pretty small, 639,000 people. I do have concerns that we could just not be an island because that giant chart you just saw of all the charges, if we're trying to do it, what are we going to do when people from New York come into the state, or Massachusetts, you're at Stowe and you break your hip, or you come here, you're in Florida half the year, you come back. I personally have concerns that if we don't have some kind of universal system for the country, that it'll be very hard in Vermont. We're just so small. That's my take on it. I'm open to anything, but I think we need a national system.
Well, we certainly need a national system, but I think we can move toward universal primary health care in the state of Vermont. I tell you what I want to do is, woman at the end of the line, you're the last person. Gentleman over there, you're the last person. Okay, sir.
Good evening. My name is Keith Schnell. I live in Bristol. My wife is My wife works at Porter. She's the president there. She's working right now, otherwise she'd be here. I'm so sorry. My wife works at Porter, and she's the union president there. She's working right now, otherwise she'd be here. I have watched her continually struggle with trying to be heard regarding poor management and a gross misuse of resources, which is in part why she was instrumental in organizing the techs and support staff there. The question is, how does the network propose to address administrative obstacles that now exist to ideas for change from patient-facing healthcare staff? Thank you.
Thank you, and thank you for your wife for working tonight. So we work with all of our staff, including our unions. I met with our union leadership team this week. We have regular, I think it's monthly, maybe it's every other month, meetings to talk about issues to work on together. I'm a big believer in people at the bedside know what they need to take care of their patients. Good contracts are good for all. They're good for the workers, they're good for us because they help stabilize stuff. So we want to hear from our staff and work to make things better.
It sounds like you may have a problem at Porter, though. Is that what I'm hearing? Okay. Could you take a look at that?
Yes.
Okay. Okay.
Hi, I'm Kara Feldman-Hunt. I'm the director of the Osher Center for Integrative Health at the University of Vermont. Know Steve very well, and Steve really helped us stand up our comprehensive pain program. We have a 67% reduction in ER visits 1 year after the program completion. It's working really well. My question is, how do we spread and scale that model? And that is really Steve's leadership that we were able to do that. But we've been really challenged at scaling that model. Blue Cross Blue Shield loves us. We're very cheap, and people are getting, it's a healthcare system, what we're doing. It's not a sick care system. But we're struggling. It will work for any chronic condition, and we're struggling to scale and spread that model. And I'm wondering if either of you have any ideas for me. And I'm meeting Steve in a few weeks, so.
Steve.
Yeah, so, I mean, you know when we built that program with Blue Cross, it's how Vermont gets a lot of stuff done. The CMO at that time, and I'm the CMO at the medical center, we said, hey, let's try this together, let's see if it works. It worked really well. You got a national conference here where we showed the amazing results we got. It takes a little belief and a little trust, and then to measure the results. I think we have the right people and system in place to grow it. We need a payer that's willing to work with us. Every single one won't work as well as the first one we built, which works exceptionally well, but I think there's opportunity to grow more of them. I really do, and you know that. I'm a big believer in this.
And Bernie, do you think that we can, I hate to even say this, but all the MAHA stuff, You know, the Maha Elevate and the whole person health stuff is all over Maha. And I wonder if there's anything we can grab there that we're not grabbing currently.
The answer is maybe. And we are looking, I mean, yeah, there are bits and pieces that we can absorb. Hi.
I'm Steve Rosenberg from Moortown. I'm on the Harwood District School Board Committee. And we've seen our healthcare costs for our teachers and staff go up 30% in 3 years. And to create budgets that our district voters will approve, we have to make cuts. Ironically, because we don't want to cut teachers, we've cut back on the nursing staff in the schools. And I'm quite worried that as these healthcare costs keep increasing, eventually we may have to cut back on teaching positions. So I just want to point out that our healthcare crisis is hurting the education of our children, and in my case, our grandchildren. And I'd like to thank Senator Sanders for continuing to push for total revolution in our healthcare system.
Thanks, Steve. Thanks, you.
Thank you.
Thank you. My name is Barry Finette. I'm from Charlotte, Vermont. I'm also been a faculty member at the University of Vermont College of Medicine and Medical Center for over 35 years. I'm a pediatrician. I've worked with Steve for a very long time. A couple of things. One, Senator Sanders, thank you so much for being the national leader in trying to reform healthcare. The healthcare crisis in this country has both a political and a health aspect to it. Without fixing it politically, you cannot fix the healthcare system itself. And Steve, I don't know if Senator has the right to call you the Vermont czar. I think he doesn't, and I think that it's unrealistic to think you're going to fix everything. So I think it's important that the general audience knows that.
Thank you.
And duly noted, I don't always support everything Steve has done, so but it's very much true. We work in a system that's a for-profit industrial complex system. It has to be removed in order to fix the healthcare system in this country. I've also been fortunate to work in over 30 low-income countries, expanding a technology that we built here in Vermont in order to provide non-physicians to do physicians' assessments of patients. Because you're trying to promote more efficient medical training, nursing training. That's really important. You will never be able to have 5,000 nurses in the next 2 years in Vermont through the training process. It won't happen. It won't happen in this country. You can't fulfill the need of healthcare professionals. And so where am I getting at? You need to look at digital solutions. There's a huge administrative burden at the hospital. There's a huge need for primary healthcare. There are healthcare digital solutions that can alleviate that. So my question to both of you is this being promoted? These are solutions that are here today. They can increase efficiency. They can allow non-physicians to provide care in the home, outside of the clinic, outside of the ER. Is there plans to do that in Vermont, a state where this can really be done because of the way it's set up and the system we have?
Steve, I'll let you.
Yeah, thank you, Barry. Good to see you. So I think what I'm hearing you talk about is, I would put it in a couple different buckets. One is telehealth, and we have a small telehealth program. I think it could be expanded. Broadband in Vermont would really help. We have a lot of houses in Vermont that don't have good service. And then AI is another part of that. We have a committee on AI right now that's trying to make sure that the AI that we're using is efficacious. It's treating people fairly. It's good for patients. And I do think there's going to be huge growth in that over the next 5 years. And I do think it can improve the productivity of our providers, which improves access. I think can improve burnout for our providers. So we are carefully looking at each and everything. We have a number of them already implemented, and I think there's going to be a lot more. I do think everything you said is true. I think we're going to be able to deliver a lot more care in people's homes over the next 5 years. We have to do it really smart and study it and make sure it actually is delivering the results that we're hoping for. But I agree.
Okay, thank you.
Yes, so Vermont needs broadband to reach every house, or you can't deliver health care through telehealth in their home.
Just a
Ma'am,
quick
okay,
follow-up.
let me keep it moving if I can, please. Yeah.
Hi, my name is Beth LaBerge, and I'm a nurse that works in Vermont. I've worked here for 30 years, both at UVM and their ICU, as well as Central Vermont Medical Center ICU. I'm also currently a cardiology nurse. I've also worked in primary care, and I also worked in dialysis. And I have great concerns. I'm very sympathetic to the fact that's going on globally in the country, but I also have great concerns about what's going on here within our state. I feel like since we have been part of the network, all these small hospitals have conglomerated with a monopoly. We have given worse care. We've had 2 primary care facilities that have closed in central Vermont. We've had our psych unit close. We've had dialysis patients no longer be able to get transplant information or services at UVM. They now have to go to Dartmouth. I feel like we have the transfer center that is choosing what patients we keep in our communities. We're a rural state, and I feel like, unfortunately, since we've been part of the network, some of the decisions that UVM has made has not served our rural communities, and I have a real strong concern about that. And so I feel like there are some real significant things that we can do in this state. We have the highest health care insurance rates of any other state, and the United States has the highest in the nation. So we really, in this state, pay higher dollars than any place else in this world. And what are we getting for it? I think that UVM can do a lot better. And I think that they really focus in on what their needs are. They're not looking at rural Vermonters. Thank you.
Thank you for your concerns. So since September, we've given significant power back to the local boards. The local boards, every board chair, so the board chair from Central Vermont Medical Center now sits on the network board. We've given back budget control to the local boards, and we've given back power over certificate of need. So I think the local boards are going to be stronger going forward. And we're focused on making sure every local hospital is able to advocate for its communities. So I think we're working on some of the things you just discussed.
I have a suggestion. Can we perhaps model what the mayor of New York City is doing? Perhaps create a council where you have nursing staff, you have educators, you have a whole group of people coming together with making decisions where they're experts and deciding what the needs are in Vermont's healthcare system.
Yeah, I mean, once again, we have to build it within the structure that we have. We do have community boards at every hospital and a network community board that is helping guide us, and those boards hear what the community needs. And I think we have some of that you're talking about right now. We have nursing professional governance. We have a significant number of groups that are putting input. We have a medical group board for the doctors. So there is a lot of input coming into the system. We have to hear it, put it all together, and deliver.
See, one of the things I learned many, many years ago when I was mayor of the city is the people who actually do the work know what the hell is going on. So it's, and it's not easy, but if there's a pipeline that you could develop that goes to the real workers who are out there in the field working every day, they will tell you what the problems are.
I agree with that, and I think the people here know I round constantly. I'm out visiting the floors a lot. I listen to what people tell me. I'm not opposed to what you said. I'm just telling you there's a lot of structure already right now that is giving input. And we'd have to figure out if we add another one, how would that fit into all this other stuff? So I'm not saying no, I'm saying we have to figure out how it would add to there is a lot of other groups giving input right now.
Yes.
Oh, sorry. Can I just say one more thing? I think we're hearing a lot of words. I think we need some really quick fixes, really small little sound bites that we can bring back to the communities. You know what I mean? It feels like this is a lot of it feels political to me in what you're saying. Sorry. Thank you.
Thank you very much.
Is this on? Okay, yeah. I'm a nurse. I've been a nurse for 11 years. I came here from Oklahoma, actually on a contract. I started working in the emergency department here. I finished last January. Had to take 7 months off because of burnout. We can't keep nurses anywhere in the United States. We're all burnt out, and that's what people have to understand. We're overworked, burnt out. The largest population of sick people right now, ever. Baby boomers. We can't take care of you guys. We don't have enough of us. And so it's really, really hard when you're a passionate healthcare worker and you can't do your job because you're fighting insurance companies, hospital corporations, and the people are getting sicker every day. So everybody here needs to understand, I know this isn't a question yet, that we are all working hard and we're wanting to make a difference. Now, how do we get people to move to Vermont? I moved here. I'm struggling. I made $35 more an hour as a traveler. I work at UVM Primary Care. I take care of geriatric patients. I talk to them on the phone all day. They can't get access. They can't get an appointment. I don't have anywhere to put anybody. Every day I walk in, no room on the schedule, all these patients needing appointments. Where do I send them? Urgent care? In the emergency room where I used to live, because I don't have anywhere to put them. We need nurses. What are we doing to recruit nurses here? It's not affordable. My wife is a nurse practitioner. I'm a nurse. We can't afford to live here. It's everything. The housing, the food, the insurance, everything is more expensive. And it's not because I'm comparing it to Oklahoma prices. It's just more expensive than anywhere. But I came here because you guys are my sanctuary state. I needed you guys. It wasn't just because of Bernie, but you were a huge reason. I've been following you a long time. But we have to get nurses here, and we're not doing enough. It is the 4th oldest state in the United States. 4th oldest. No offense to anybody here that's old, I'm 45. But we have to get nurses to move here, and we can't right now with the cost of living the way it is. So my question is, what are you doing to recruit? Where's the recruiting?
Thank you. So I can tell you that we are having some success with recruiting. Our retention is really good. Our turnover is about 10% right now. Best in class nationally is anything under 12. So the people that we are recruiting are staying, which is a good sign. And our traveler numbers are way down. The last 3 years, each year they've come down 20 to 25% or more. We have some housing available. We're helping with childcare. We're advocating for more housing in Vermont. We're advocating with community leaders to try and figure out how to make Vermont as affordable as possible. I think this is one of those issues that's going to take more than just UVM Health. It's going to take all of Vermont and some federal help as well to help bring down the cost of, it's an expensive place to live.
I just want to pick up and thank you and all nurses. I was the chairman of the committee, and nurses throughout the country would come into our office. And I never really quite seen anything like it. They were coming in and not complaining about their wages. They were coming in because they were burned out. Their staffing was inadequate. They would go home at night feeling that they hadn't done the work that they wanted to do. They were overworked. It's just in New York City, there's a big strike going on in New York right now as we speak. So nurses are the backbone of our healthcare system. And we've got to do a hell of a lot better job to make sure that staffing ratios are appropriate, they're paid appropriately, we recruit the numbers that we need. So, okay, thank you.
Hello, I'm Jacob Berkowitz. I'm one of the union leaders that Dr. Leffler met with a couple of days ago. I first appreciate you both for being here and putting on this event. It's really great. I heard a lot of Bernie talking about we need visionaries in charge of the healthcare system, and I hope Dr. Leffler can be that visionary. I really do. You were a little waffly on, very political about your answers about the proposition for universal primary care. I hope you reconsider and meet with folks. But you also mentioned that a lot of the reason that you feel that way is beyond just needing more information is you believe a national system would be better. I certainly agree with that. Would you be willing, publicly to endorse and work with Bernie on getting a single-payer Medicare for all system that would transform healthcare in this country when obviously there's a less insane federal administration running the show?
It's a good question, Steve.
So I've said many times to Bernie, we've been meeting for a number of times, that the way healthcare is paid for now in the United States is broken. We just saw a great example where every clinic has multiple payers, every hospital has multiple payers. I'm a firm believer in a single payer system for the country. I don't think Vermont can do it alone. I just think we're too small, and it won't actually work because we have so many people coming in and out of the state all the time. So I have issues in Vermont. I would be happy to work with Bernie on advocating, and I've said it publicly a number of times that the system right now is not working well. We know that by all the people that are still here tonight. We have a broken system. I would work with him, yes.
All right, and I think where Steve could play a great role is, I suspect you're not the only hospital administrator in the country who feels that way. And we got to bring them together. I mean, that's just one more voice that says the current system is broken. We got to move to a single payer system, yes? Okay. All right, last question right here.
Thank you so much for being here. Thank you for being here tonight. Dr. Leffler, my wife and I started an independent primary care clinic in Waterbury. And at our size, we actually don't lose money on Medicaid and Blue Cross, which is good.
Congratulations.
Thank you. Thank you. They're actually nice to work with. The rest, we're so small, we have no leverage with those companies in negotiation. We've talked a lot about group purchasing and your support for independent practices. So would you work with independent practices like ours on group contract pricing, especially for some of those out-of-state insurance providers, so that at least we can compete on a level playing field? Thank you.
It's a great question, and I'm going to give you, it's going to sound like a political answer. I don't mean it to. We have to be careful of things we offer you if you're sending patients to us. There's federal laws around how we do that. I do think there's a lot of back-end support we may be able to offer you that would be okay. So it's not a no, but I don't want to say yes, we can definitely do it, because there are federal laws around. If you're sending patients to our ER or getting imaging with us, we have to be very careful about what we try and do to potentially help you. So I just want to say that. But yes, I think we can. I want to help all providers in the state in ways that we can do that are legal.
I'll give you my card.
Sir.
Hello, my name is Emmanuel Diamant. I just graduated with my BSN from Norwich, September 2025. Thank you. My question definitely comes after that reflection. So I've worked in home care, skilled nursing homes in multiple states, Pennsylvania, Colorado. One of the reasons I came to Vermont was because Vermonters, in the middle class especially, they have a good median wage. You can come to Vermont and you could make a good living as someone that really just got out of college. And other states, you can't say the same. Sometimes if you get a degree, you don't necessarily have that guarantee. So one of the things that I really just want to ask you with that in mind is, we know that the system is broken, right? Right now we pay 10 times more for emergency care because people can't access primary care. We reward travel nurses that pulls money out of our state systems, our pensions, our unions, and turns instability into a business model. And we make becoming a nurse so expensive that people, and this is my own numbers, going to Norwich, my total cost was $170,000. And that it also includes, as I was working part-time, and that includes $40,000 of lost wages. Okay, so imagine that. Someone in the middle class having to sacrifice $40,000 to go to school for nursing and fill that 5,000 worker gap. So the question that I have for you, how do we stop rewarding crisis and churn and instead rebuild a system that pays local workers, guarantees access, and makes nursing a sustainable career in Vermont? Thank you, Dr. Leffler. Thank you, Senator Sanders, for your time.
Thank you. Well, let me jump in there. I mean, just one more example of the irrationality and insanity of the current system. We desperately need nurses. You're hearing that all night long. you're graduating $170,000 in debt, right? You spent $170,000.
It was like 130, and then 40 lost,
All right.
lost wages. So.
So here we are saying to people, we desperately need your help. Oh, by the way, it's going to cost you $170,000 to get the job. Correct me if I'm wrong, and I don't think I am. I've talked to young physicians who are leaving medical school $500,000 in debt. Got it? Desperately need more doctors. Oh, by the way, if you're in the working class, middle class, you're going to leave school $500,000 in debt. It is totally insane. We have introduced legislation. Now, the good news is, for years I've been fighting to make higher education tuition-free. There are now, I think, 4 or 5 medical schools in the country that are, in fact, providing, they have good endowment programs, privately done, free tuition. The goal is simply got to do what other countries are doing. You want to go to nursing school, you want to go to medical school, it's going to be tuition-free because we desperately need you. All right, question right behind. Yeah, ma'am.
Thank you.
Thank you.
My name's Sophia Simpkins. I am a proud officer of VFNHP, and I'm also a triage nurse at South Burlington Family Medicine, so primary care. We talked.
Hold the mic a little bit closer.
Okay, is this better? I don't like the sound of my voice, so this is rough. We talk about administration, the cost of it monetarily, but it also causes huge amounts of inefficiency. And I wanted to give 2 quick examples of that. The first is, this was pre-Leffler's promotion reign kingdom. We hired a per diem nurse. We are 1 FTE down. We're down a nurse. It's been rough, like in triage. We're not the people who room you. We're the people who sit on the phone. We answer your my charts. We're drowned in messages, and we feel like we're dying every day. So we really need that extra nurse. And they allowed us to hire a per diem, because we got it in our contract. And a per diem is a nurse who's hired as needed. So they don't get benefits. They're a little cheaper. We hired one. She showed up to 2 shifts, and then she was like, peace, and left. We had to go through so many layers of leaders to have it be reapproved to post the position. It took months for it to get reapproved, to the point then that the other people who had originally applied for it, that we could have gone, whoop, you are a second choice, let's slip you right in. They were like, why are you contacting me? It's been months. I've accepted a different role. So inefficient. Months of time where we just could have had extra help and we just didn't have it. Admittedly, maybe we should have made a better choice.
Steve,
but anyway.
good question. All right. Why does it take months to get a nurse?
Yeah, so I understand what you're talking about. We were trying to be very careful on our hiring right now and make sure everything fits ratios. That's a failure. We have to do better. We're working on it.
Okay, I appreciate it. And my second example, if you'll allow me, is when it comes to access. A couple years ago, I don't know if you remember, we spent millions of dollars on an external consulting company. They came with clipboards, sat behind us, stared at us all day. They made a lot of suggestions. I think we've reversed 50% of them at this point. But they base the patient panel size off of the clinical FTE of the provider. What they don't take into account with the panel size is that that provider is not going to be available 6 weeks out of the year for their vacation and their continuing education, like CME time. I have 15 providers in my practice. I know, yeah. It's about a year and a half of appointments that don't actually exist, but the patient panel sizes are growing like they do exist. So when we're talking about everyone who's like, why can't I see my doctor? Why can't I get in? Why am I always going to urgent care? I guess my question is, I know you're very high level. I know we're talking about very high level stuff that maybe you don't even have control over, but I think there's so many examples that I don't even know about across the health network of little things like that that need to be like hunted down and eradicated, because those are the things that would improve our care.
We're working on it right now. We're working on making sure that schedules are optimized and accounting for those issues. So I hear you.
Okay, I hear it. It's when I brought them to my
Okay,
leadership that I got told that's not a problem. So that's why I'm bringing it up.
Okay.
thank you.
Woman, you're the last question.
Hi, my name is Jennifer Carpenter, and I live in South Burlington, Vermont. And first of all, I just want to say, Bernie, thank you so much for your relentless advocacy for everyday Vermonters and everyday people across the United States. Thank you. Thank you. And Dr. Leffler, I also want to thank you because from my observation and personal experience and what I've witnessed at UVM Medical Center, when you can be seen there, and when I've gotten care, or when I've had other people I know getting care, it's been outstanding. So thank you to you and the fine medical staff that work there. They're really excellent. With that being said, I have read that UVM has been reducing the amount of hospital admissions overall. It concerns me that I repeatedly hear from UVM healthcare administrative leaders that elder care is an enormous cost burden. I'm hearing the pain on that, but I fear that age discrimination is a factor in senior people getting treatment at the hospital when they need it due to the costs that their care incurs. And I say this, I personally have experienced accompanying an elder to the emergency room who was denied care in a life-threatening situation. I know that can be subjective, but when the nurse agreed with me that my elder should not be pushed out of the ER, it really felt like in that moment of crisis that there was a corporate and real hierarchy presence that was pushing us out the door. And I just don't feel that a patient should ever have to be in that situation. And it's really difficult to be in that situation. So somehow when we were able to get them to stay, my elder, and they were admitted to the ER. But once they were allowed to stay, they got excellent care. But we really had a hard time getting admitted. But because they were admitted, the hospital saved their life. How can we ensure that we are not going to be reducing hospital admissions? And how can we ensure that we don't, when it's obvious that an elder needs life-saving care, that we don't experience an overscreening or an age discrimination?
Thank you for your question, and I'm sorry for the experience you had in our ER. We are committed to caring for everyone. We are not discriminating against elders, I can assure you of that. When we talk about Vermont being the fourth oldest state, older people need more care. That is a universal truth. And so that is one of the issues we have to make sure we have the capacity to care for everyone who needs us. We are totally focused on that. In terms of our census, how many patients we admit to the hospital, our census grew by 50 beds during the pandemic. We're back to post-pandemic now. We're trying to make sure that our census is exactly right and make sure that the amount of time people stay in the hospital is exactly right, and that's been able to make our census get close to, it's actually not down as much as it was before the pandemic, much better. So that's all we're trying to do, get back to the size of the hospital before COVID was here. Thank you.
Thank you.
All right. Well, thank you. Let me thank everybody for coming out tonight. There is no question in my mind that virtually everybody in the state of Vermont understands that we have a major healthcare crisis. My dream is, as has been the case in many other areas throughout our history, that this small state, which is really made up of very, very decent, compassionate people, can help lead this country in a very different way in terms of healthcare. And we've got to do it all together. I think Steve is doing his best in a broken system. I think we've got to make sure that we work with him. And Steve, I'm going to keep pushing you.
Fair.
All right. But at the end of the day, it is beyond disgraceful that so many of our people in the richest country on earth are uninsured or underinsured, that we have these massive bureaucracies that impact nurses and doctors and patients. Goal of life ain't hard. When people get sick, they should be able to get high-quality health care from being a baby to their dying day. That's what it's about. Ain't hard to understand. That's our goal. Let's go forward together and make it happen. Thank you all very much.
Hi, I'm Adele Derazette. I go to this church and I work in AV, so I'm normally behind the camera, but today I am in front. And I just want to ask you, why did you come here?
Because I was invited.
Is there anything else you'd like to say to the camera?
Yes, this event is about medical health, but mental health and medical health are directly connected. I have a friend of mine, a real friend, that can't keep out of trouble. So she's using the judicial system. She's staying in jail. She's using jail as emergency housing. While she's in prison, the art therapy seems to be clearing her mind. It's working. There's nonprofits from out of state that do work with different jails in their state, and I'd like to link them up to this state where the Department of Corrections can have like a registry where art supplies can be donated to the jail, but when they have a surplus, it can be released to other art programs. Because what's going to happen is people are going to run to the dollar store and get all the art supplies, and then they're going to have too much. So it's going to be from not enough to too much, and if there's too much, it has to be allowed to be released to other art programs, an after-school program or the senior center.
Okay, thank you. What is your name?
My name is Annie Kramer.
And why did you come here today?
I'm a resident of Bennington County in Bennington, Vermont. And I came here because Bernie's my hero and has been for many, many years. I also wanted to hear what the CEO of this hospital locally has to say. I'm a registered nurse, 20 plus years in the business, worked my entire career in the hospital setting with mothers and babies. I did not have a pleasant experience. Majority of my career was in a non-unionized hospital, so I'm a big advocate for unions, for nurses and other opportunities, careers. I just recently finished my memoirs, Dancing Amid the Wolves, on my memoirs in working in the hospital system and all of the breakdowns that I saw occur during my career. Some of them were so illegal that I couldn't even really put them in the book. Breaking federal laws, distribution of Medicaid funds illegally, sapped from immigrants who were hardworking people and had to give a cash deposit before they went into the hospital for their surgical procedures. Those funds were stolen from them, and they never knew. And when I found out about that, when I found out about the way that the administration of that hospital was abusing the system, it broke my heart. So I am here to hear what the CEO has to say, what Bernie has to say, and thank you all for giving me an opportunity to speak.
Okay, thank you very much.
Again, back to the mental health and physical health are connected, but preventive measures. So, I'm not wrong. I thought he was laughing at me. How about don't get sick in the first place, and then do the physical therapy before you get an order from a doctor to do the physical therapy. We can get the outdoor physical therapy equipment that's in public parks all over the country, copy and paste what works over there, bring it over here. Same thing with the mental health stuff and the art supplies things that I was mentioning. Just origami keeps the brain working. And then we bring the different generations. That's the bridge. So you have different people just collaborating on an art project. And that's a way of expressing yourself without damaging other people's property or hurting your own body.